But I do want to say what an honor it is for Tony to invite me, and I've only been here about a year, but I have to tell you that I am so impressed with the work that Tony has done and his team and the resources you have here at the Mind Institute. You are very lucky to have that. I'm very lucky to have the association with it, and I think Tony should and team should get a big hand, not only for the today, but for all the work he's done. He really is a very special person and has done some great work. And it is an honor for me to work with him. I'm going to take you through a whirlwind tour of 22q. And a lot of this you know, and I would tell you that probably most of you know more about this than I do. So some of the stuff that I think you covered this morning, some of the stuff that you already know, I'm going to go through pretty quickly. Obviously, I want to focus on the cardiac stuff because I am a cardiologist and give you a little bit of a background and review of that. I want to challenge you also and present something to you that's a little bit provocative, something that we started thinking about in Wisconsin with the work that some of our molecular geneticists have done. So I'll get there. We'll talk about that. The stuff that I want to present to you may not be ready for prime time, but I'd like to get your opinion on it. So obviously you know that here is the issue. I apologize for calling it the DiGeorge critical region, but I think it's still called that, despite the fact that we are now calling this 22q on the chromosome. This is where the action is, and this is where the deletion is. And from my standpoint, actually from all of our standpoints, is the fact that this area on that chromosome really responds to or is involved with the conotruncal region. And the conotruncal region, that so-called region embryologically, is very important for thymic development, parathyroid development, fourth and fifth arch development, which is key to certain parts of cardiac development. We'll get to that. And again, you know all of this. This area houses all these very critical parts embryologically that must form correctly in order to form the correct organs related to those issues. And so that abnormal development of those areas can occur, and abnormal development of specific target areas can occur as a result of that. Again, I know I'm reviewing this, and it's a review, and I apologize for going through it so quickly because I do want to get to the other stuff, and I know we'll have some time to answer questions about this. And so it really is that deletion, which we heretofore these days call the 22q deletion, which is found in patients who historically and traditionally were labeled in the old days, and I remember the old days because I'm old. And I remember the first time I gave a talk about this, which I won't tell you when it was, well, I'll tell you when it was in we called it DiGeorge Syndrome, and I had on my slides DiGeorge. And so historically, these are probably very different, very similar syndromes, and the nuances aren't important because we're going to call it 22q, and 22q is what we're going to talk about from a multi-organ standpoint. And so this historical perspective, which for some groups, not this, I would spend more time talking about based on 1965. Trust me, I wasn't practicing medicine back then. I'm not that old. But this was certainly probably the first description of that. And a very important part of that description way back when was the description of congenital heart abnormalities in association with it. We're going to get back to that and get back to that in great detail. Then this other syndrome, which I don't think anybody talks about anymore, but certainly existed, called the Conotruncal anomaly face syndrome, was described a little later, probably similar with some variations on that. Then, of course, this is probably one of the more recent iterations of that VCF, described by Dr. Sprintzen in 1978. Again, something you've heard of. And for all intents and purposes, we've learned a lot. A lot of what we've learned is that these are not separate, that there is a wide variation depending upon the penetrance and other genetic aspects that, again, I think you all know about. And they're probably all very similar in terms of the diagnosis. And I think really, and I went through it quickly because I didn't think it was important, and I think you knew it, what is important is this, that it is, and it being 22q, a multi-system disorder with many common significant problems and variation in those problems, but we know that probably about 75% of patients with 22q at some point in their life have a combination of immune disorders, and you're going to hear about that next. So I do have a couple slides on that, but I'm not going to throw it in. Congenital heart abnormalities, palatal abnormalities. About half of the patients with 22q have hypocalcemia, the endocrine issues. About a third have renal, feeding, hypothyroid problems. And of course, there are a subset of patients, and you know this, you heard about this in the last talk from Kathy, have intellectual psychiatric problems. What I don't have on this slide, and it fits in with this, and I do want to focus on that, is the neurodevelopmental problems associated with this. This is key, and I'm going to get back to that, but I want to make sure that it's understood what a key part of that is, not only with 22q, but even with congenital heart disease. Even if you had congenital heart disease independent of 22q, neurodevelopmental outcomes are now a very, very key part of what we talk about. They weren't before. In my world, 15, 20 years ago, we were just hoping that we could figure out how to get patients with significant congenital heart disease to survive. We've gotten much better at it. We're better in the intensive care unit. Our surgeons are wonderful, and they do a great job. So survival, almost in our world, is now expected. That's the norm. But it's not enough to say that we're going to get a patient through and get them to survive. We want to figure out how to get them through and get them through with the best neurodevelopmental outcomes. More on that, but I want to tell you that's a very key part of my world and what we do right now. So what about the heart in this particular issue in 22q minus? Some form of congenital heart disease exists in anywhere from 75 to 85% of patients who have 22q minus. Most, and not all, and this is a very important concept. In the old days, we used to think that the only issues that you got in 22q minus were the conotruncal abnormalities, but that's not true. Most of them are. And what are those conotruncal abnormalities? Interrupted aortic arch is a big one. 50% have 22q minus. Truncus arteriosus, more than 50% have 22q minus. VSD, which by the way is not classically described as a conotruncal abnormality, 25% of those patients have 22q minus. And tetralogy and its variants, specifically tetralogy with absent pulmonary valve syndrome, have a relatively high incidence of 22q minus. Transmission double outlet are less common, but I would tell you that any congenital heart abnormality is a possibility for having 22q minus, primarily the conotruncal abnormalities. In one series of patients that were studied by Goodship back in 1998, 9 out of almost 70,000 births had 22q minus, and of those, 6 of them had significant heart disease. As opposed to, and I apologize for the typo, 53 of those 70,000 had Down syndrome, trisomy 21, and 15 of them had significant cardiac disease. So generally speaking, 22q minus has the second most common chromosomal cause of significant congenital heart disease. That's an important point because we didn't realize that many years ago. We're realizing it now. Now, back to what I showed you a little earlier, the conotruncal abnormalities are listed on this slide here: tetralogy of Fallot, truncus arteriosus, TET with absent pulmonary valve, interrupted aortic arch, truncus with an interrupted aortic arch. So if we see babies with those, it's very critical for us to screen for 22q minus. And we're going to talk about the screening because there's some controversy behind that. So here's what I'm going to show you as somewhat provocative, and I apologize for the slides I'm going to show you because they're a little blatant, but I want you to see this. And back to the slide I just showed you a little earlier, one of the questions that I'm going to throw out there is early diagnosis beneficial? And if the answer to that is yes, and obviously I know the answers to that is yes, and you know the answer to that is yes, what can we do to figure that out? And I'll tell you why it's important, because I'm going to show you 2 different patients. This is a tale of 2 patients, and they both have 22q minus, and they both have interrupted aortic arch type B. So here's patient A. Patient A was discharged from the hospital 2 days after birth. We didn't know that this patient had interrupted aortic arch, and we certainly didn't know that the patient had 22q minus. Went home, the PDA closed, and this is a patient who has a cardiac abnormality that requires the PDA to be open. The baby came back to the ER in shock. in cardiogenic shock, suffered a stroke, got admitted to the hospital, the Children's Hospital. This was when I was in Milwaukee in Wisconsin. Ended up going to the operating room, had additional surgeries that were required. The hospital bill was about $750,000, and I don't care about the hospital bill. That's not the point of this, not the expense of care. The unfortunate part is this baby developed and ended up having horrible neurodevelopmental outcomes because they presented with a stroke. Patient B was diagnosed in utero by echo. We know ahead of time this baby had interrupted aortic arch, got started on prostaglandin, had surgery before they got discharged. And the two differences here is that the one on the left, in the patient who did not present in shock, did not have a long length of stay, didn't require medicines for a long period of time, was in the hospital for a shorter period of time, as opposed to the patient on the right. And the two important concepts here, clearly, and now you don't have to be a rocket scientist to figure this out, is if you present without shock, your hospital bill is less, but you do better. Again, I'm not focusing on the finances here. I want to emphasize that. And the average difference in price was much less, but more importantly, these patients did better. And one of the things that I wanted to provoke you with is the fact that there is the ability for us to maybe make a diagnosis early in life. We know that about 3/4 of the patients who have this have significant congenital heart disease. Most of them are ductal-dependent congenital heart defects. There's an increased morbidity and mortality. This patient survived, but and mortality with a late diagnosis. And my colleagues in Milwaukee were able to come up with a blood test, and I won't make you repeat this to me, but it's called multiplex PCR. It's a simple blood test that you can do on babies after birth to make the diagnosis of 22q minus. And if you make that diagnosis, it would force you to look for significant congenital heart defects. This is a test that's sensitive and specific, meaning that you won't get false positives and you won't get false negatives. All the lines there in red meaning show you that you can make this diagnosis literally on day 2 of life. And this is a newborn card. You do screening cards here in California also. We do it in Wisconsin. And if you added this to a screening card, you might be able to make this diagnosis early. So it's sensitive and specific. It's amenable to high output screening. It's cheap. It costs $6. It's technology that exists. So one of the questions really that we struggle with is, can you get the result back quickly? And if you could, this would be something that might be worth advocating. I'm going to skip through the other systems because you're going to hear about it later throughout the talks. You know about it already. Palate problems, endocrine problems. You're going to hear about this in the next talk. Feeding disorders you're going to hear about and know about. This is critical, and I can't overemphasize this because what we're doing and as we're going forward and the work that's done at this particular institution is going to be critical as we go forward. And how we should screen, I think, remains to be seen. This is a topic for discussion. Do we do FISH alone? Do we do microarray? Should we talk about doing this PCR in order to make the diagnosis soon? And believe it or not, there are some people out there who say that we should screen not at all because it doesn't make a difference. I don't believe that. I don't think you believe that. But there are still people out there who say that, and I'm just throwing that out there for the sake of completeness. So I'm going to finish up because I'm going to get the hook very soon if I don't. And I know we will have time for questions, but in summary, once the genetic diagnosis is made, we have to consider everybody and everything, and I don't have to tell you guys that. There will be a collection of problems which can be variable, and what I cannot emphasize enough, and you know this, is that a multidisciplinary comprehensive evaluation is best and will meet the needs of everybody, and this is the most critical part of what we're doing and how we're partnering with all the people in this room. So thank you. I'm sorry for going fast. There was a lot to cover, and I know we will have time. We'll have some time right now, but I know we'll have time in the follow-up session. The question is, if the child does not have the issues when they're younger, can they develop when they're older? So let me qualify that by saying that if the children are adequately screened for congenital heart disease, in my mind, if you have 22q minus, you should have an echocardiogram. I mean, that's the only way to really diagnose it. So if you get screened and you have an echocardiogram that's normal or doesn't show something significant, you can't grow it or you can't develop it. These are all congenital cardiac abnormalities, meaning that you're born with them. You may not be able to diagnose it right away, but an echocardiogram will diagnose it right away. So if you have a normal echo, or you have an echo that doesn't show significant congenital heart disease, you can't develop it later. I think there was another question?
Same question.
Okay, yeah. And I do firmly believe, and I don't think that's very controversial. If you have that diagnosis made, if you get an echocardiogram, the echocardiogram should be done in a pediatric cardiac center with people who are used to doing them and interpreting them. But if you get the clean bill of health, then you've got the clean bill of health, at least from a cardiac standpoint. It doesn't rule out, as you know, the endocrine, the ENT, all the other stuff, but it rules out the cardiac stuff. We had tried a few years ago to advocate for the PCR to be, at least in Wisconsin, to be a routine, not only in Wisconsin, but throughout the country. And actually my colleagues and I, the people who were on that paper, went to the FDA, we went to Washington and presented this data with these two babies and said that, and we went to the state also, the state of Wisconsin, for this $6 test, if you would advocate for it, because it would have to be approved by the state lab of hygiene, at least in Wisconsin, and then by the federal, by whatever committee Janet Sebelius used to be the chair of, and we were hoping they would give us the go-ahead and give us the mechanism to make it routine. They didn't, needless to say, and we're not done with it. And obviously, at a federal level, and you guys know better than I do, I think there's a group of people at CHOP and in Philadelphia who are the advocates for 22q, and I know many of you are part of that. We haven't given up on that, so we'll go back and maybe someday, this will be a possibility. I mean, congenital hypothyroidism is not a common abnormality, but we certainly, the outcomes are devastating if you don't find it, but that's on the card, and we screen for that, so why not screen for this also? But we're working on that. That may be available sometime routinely.
I'll just make a quick comment. I mean, from what I've heard of these discussions, and I'm no expert at all, but I'm part of these larger meetings, the resistance that comes up frequently, and because this is generally a state-by-state decision, is that the argument is you don't have a cure for the disorder, so why screen for it? Now that's a very short-sighted notion because you don't cure 22q, but there are all these manifestations that early detection could prevent and reduce. And so I think the problem is we have to do a lot more work to convince these folks that you shouldn't be thinking about cure, you should be about prevention and remediation, and you as you said, financial numbers are not the outcome that we care about, right. But those people will take a lot of notice if the medical bill and the bills to the society are reduced by hundreds or thousands of times. What we really care about is the quality of life for the individuals, of course. But those things are not uncorrelated with one another, and for bureaucracies, you often have to show them the money numbers.
Yeah, and I think there's a lot more to come on this. I don't think this discussion is done.
No, it's very far from over, and I think there's a constant progression for us in the research and the clinical community to continue this barrage of conversation. And this, by the way, also happening in Fragile X at the same time. There's very similar discussions happening there too, to show people there is real value for doing that screening.